Hello, and welcome to Resilience Radio. I'm Irvin Eisenberg. Not exactly hosted the show today, as this is a clip from another podcast where I'm being interviewed regarding some neuroscience of pain study. This episode gets very technical, and the podcast that it originally aired on was not intended for a general audience. It was really intended primarily for occupational therapists receiving continued education. And it is me discussing some of the implications of a particular study that we're talking about, as well as getting a little more in depth about some of my philosophy on pain management and chronic pain.
I once heard a neuroscientist say that many of our frameworks end up being wrong because the body is more complicated than we ever imagined. Pain science perfectly illustrates this. We are living in an era where new frameworks are being written because classical understandings of pain have not only been inadequate, they have led to ineffective and even harmful treatment. Today, we look at a new framework for understanding pain. And there's good news for OT in it. The author argues that such a complex condition needs holistic treatment like OT and PT can provide. To help us unpack what this can all mean for your daily OT practice, we are so excited to welcome to the podcast Irvin Eisenberg, MOT, who owns Resilience Occupational Therapy, where he helps members of his community manage their pain. So let's dive in. Welcome to the OT Potential Podcast, where we review new and influential OT journal articles, then invite on an expert guest to help us pull out actionable takeaways that you can implement in your practice starting today. Welcome to the podcast. I'm your host, Sarah Lyon, OTRL. And before we dive into this big topic of pain and OT, I wanted to let you know that this podcast may qualify as continuing education for you. You are probably listening to this podcast on a free podcast platform. But to gain CEU credit, you will need to be a member of the OT Potential Club, our OT continuing education platform. Bearing in mind that this could count as a CEU course for you, I wanted to state our two learning objectives so you can be thinking about them throughout the podcast today. Our first learning objective is you will be able to identify research-backed OT pain interventions. Our second is you will be able to identify assessments that you can use for pain management. So let's begin by looking at this journal article, and then we will bring on Irvin to discuss how this could play out in your practice. The article we are reviewing today is called The Distributed Nociceptive System, a framework for understanding pain. It comes to us from Trends in Neurosciences, and it was published in 2020. So the article begins with this big picture introduction to chronic pain. Chronic pain affects more than 30% of the global population, making it the leading cause of disability worldwide. Part of the reason chronic pain remains so widespread and debilitating is that our understanding of the systems behind it is sharply limited. We still can't fully explain the central nervous system mechanisms that process potentially noxious information into our subjective experience of pain. The article refers to this process as the nociceptive system. So what is the problem with our classical understanding of chronic pain? Focusing on single neurons, single molecules, or single brain regions has left us with an incomplete understanding of pain, thus rendering our efforts to develop pain treatments largely unsuccessful. Many of these efforts have revolved around pharmaceuticals. And in short, we've been looking for a pain-busting miracle drug. But medications for chronic pain remain just largely ineffective, and new drugs often fail to outperform a placebo effect. Meanwhile, more effective and holistic therapies for chronic pain, like OT and PT, are underutilized and are under-reimbursed. So what was the intent of this specific article? In this article, a leading pain scientist, Robert Coghill, PhD, lays out a framework for understanding pain. He calls it the distributed nociceptive system. And full disclosure, there is a ton of complicated science in this article, so I am going to stay focused on the really big picture takeaways. So we'll start with the distributed processing of nociceptive information with the spinal cord. Recent research now indicates that the spinal cord by itself has the ability to encode multiple dimensions of sensory information, like intensity and location, and it has the ability to formulate complex motor responses to noxious stimuli. Historically, we've been taught that the dorsal horns of the spinal cord are engaged in sensory processing, whereas the ventral horns are engaged in motor processing. In the club, I'll even share a graphic that reinforces this understanding. But we now know this classical understanding of pain to be untrue. Pain processing actually is distributed across both the ventral and dorsal horns of the spinal cord. Additionally, nociceptive input historically has been ascribed to lamina 1 through 5. This has also been found to be untrue. Nociceptive processing is distributed across multiple lamina throughout the spinal cord. So in short, in this section, processing can take place at multiple locations along the spinal cord, making this signal extremely hard to disrupt. Unfortunately, these classic tenets of pain that I have mentioned have led doctors to surgically cut the spinal cord in order to alleviate chronic pain, only to have their patients' pain return. The theory here is that over time, an alternative pain pathway becomes engaged. So that's pain at the spinal cord level. Looking at the distributed processing of nociceptive information at the brain is our next section. And in the brain, the story is the same. We are discovering redundancy upon redundancy, ultimately ensuring that pain information is processed, even when one tract or large portion of the brain is damaged. For example, classical views of pain once associated sensory processing with the lateral nuclei of the thalamus and motivational processing with the medial nuclei. And we now know that both of these brain sections have the ability to process pain. Part of what we now know about pain processing comes from advanced science around particular brain regions. But we've also added to our knowledge by studying cases where specific brain regions are injured, and yet somehow pain persists. In what the author calls a horrific example of the resiliency of pain, he describes the case of a patient who had facial pain following shingles, and surgery was performed to resect the sensory root of the trigeminal nerve, to excise the contralateral somatosensory cortex from the face, and to excise the ipsilateral somatosensory cortex from the face, and excise the bilateral prefrontal cortex. Basically, anything that they knew at the time that might carry the pain signal was severed. And yet, the pain remained. This all leads to the central tenet of this new pain framework, which is the extraction and utilization of nociceptive information is a process that can be accomplished separately and largely independently by multiple sites within the central nervous system. So after a lot of science in these two sections, the author closes with some ideas for solutions. This final section is called Pain, a Distributed Problem Calling for a Distributed Treatment. We can now see why surgery often fails to disrupt pain. We can also see why medication targeting a single neurotransmitter or neuromodulator is so ineffective. There is a clear need for treatments that target distributed systems. And luckily, these treatments do exist, but they are simply underutilized. The author highlights two main categories of such treatment. The first is multidisciplinary treatments incorporating cognitive behavioral therapy. And this is a section where OT is explicitly mentioned. The author states that emerging evidence indicates that multidisciplinary teams who incorporate cognitive behavioral therapy into treatment can substantially alter pain by targeting multiple brain areas. Specifically, combined cognitive behavioral therapy, physical and occupational therapy has been shown to decrease connectivity of the left amygdala with the prefrontal cortex, the motor cortex, the cingulate cortex, and the anterior insula. He also mentions mindfulness meditation as a treatment. Compared to a topically applied placebo cream, meditation has been shown to produce greater reduction in both pain intensity and pain unpleasantness. It has also demonstrated a distinct pattern of deactivation in the cingulate cortex. So, headed into his conclusion, the author states that extraction and utilization of nociceptive information can occur at the lower levels of the nervous system and across multiple distinct brain regions. The framework put forth in this paper helps explain why the nociceptive system is so resilient and thus difficult to disrupt. We still rely far too heavily on focal pharmacological modalities, and we fail to capitalize on the tremendous power of the brain to regulate pain. Bottom line, there is a critical need for multimodal treatments aimed at addressing both chronic and acute pain. There is so much to unpack from this article, and I do want to highlight that we have done 2 episodes related to pain already, one that focuses on mindfulness and one that focuses on acceptance and commitment therapy. I think those would be great to listen to with this research in mind. But for today's discussion, I really wanted to find an outpatient OT practice owner who is doing this work full time. And that's how I got connected with this week's guest, Irvin Eisenberg, MOT. Irvin's interest in body and health started in college, where he studied dance and choreography at Bard College. And while he loved dance in the human form, he had very little talent for dance and exhibited poor rhythm. Thus, he left college to go to massage school and graduated from the 1,000-hour Finger Lakes School of Massage program in 2007. As a massage therapist, Irvin became fascinated with the connective tissue, or the fascia, and studied under a Rolfer for 2 years before attending Tom Meyer's program on structural integration. Wanting to meet more of his clients' needs, he went back to school at Utica College to complete his bachelor's and earn a master's in occupational therapy. Since graduating in 2018, with his broader skill set and the ability to accept insurance as payment, he's been able to help an ever-growing number of people in central Vermont. So without further ado, I will patch Irvin into this podcast. Welcome to the podcast, Irvin. It's great to have you.
It's great to be on. Thank you.
I am so thankful that you're here today. This article was so dense. There was so much to unpack, but it was really humbling to get to the end of all of this science and hear these recommendations for treatment approaches that are holistic, like OT, PT, mindfulness, and just the need out there for more practices that address pain in this way. And I'm so just proud of your practice and how you've been able to do that in Vermont. So I'm excited to talk about the science of it, but also about what your practice looks like. But before we get to all of that, I would love to just hear a little bit about your backstory and how you became interested in OT and pain in the first place.
Well, I started off before being an OT as a structural integrator, which is a type of manual therapy that focuses on posture and fascia and sort of whole body tissue tone. And I was working with a lot of people, and sometimes things happen weird with pain. There are times when I'd be working with someone's back, and after a session, they'd just be like, "You cured me." And they'd be like, never again did they complain of back pain. And I'm like, I just didn't do enough that mechanically speaking, that shouldn't have done it. And there were other times I'm more ashamed to say, but I think it's important that we focus on the things that didn't work as well. I'd be working with someone's back, and I also just didn't do that much. And they were like, that hurt a lot. I was in pain for the next couple of days, and I don't want to see you anymore. I'll be like, it didn't register. The biomechanical things that I was doing wasn't equating to the degree of pain that they were experienced necessarily coming in or experienced afterwards. And it's something I wanted to get a better handle on. Additionally, I was always interested in sort of the interesting stories you'd hear of like mirror therapy magically curing somebody's pain upon who had severe, usually the classic thing is the hand pain that somebody has, phantom limb pain, and by seeing the non-affected side in the mirror and seeing it moving and that not increasing the pain just would immediately change the nervous system on that and get rid of the pain. we tend to hear the glorified versions of that, not necessarily the clinical versions. But I was excited when I decided to become an OT to discover that mirror therapy was sort of in that realm of what an OT does, that what practitioners would be doing, that it would be actually more the OT than the neurologist who doesn't have the time for that. But in any case, I became interested in pain was sort of paralleled my work as a manual therapist doing the structural integration work, as well as once I decided to become an OT, that was sort of in the background as well. And I was at a continued education class, and the instructor was mentioning Adrian Lowe's work, and I went and I looked into some of his educational modules and tools for teaching clients about pain, and I found that very useful. So that started me on the more formal path of working with neuroscience of pain work with clients.
You bring such an interesting background to this pain work, like your background with the manual skills and then interest in the neuroscience of pain. And I just remember as an early in my OT practice, wishing I had more of those manual skills to bring into my sessions with clients, seeing that as like a helpful pillar of pain treatment and something that I didn't feel as equipped from OT school as I would have liked. And it's interesting now after reading this article to think about all the different skill sets that we could bring to pain, and I guess just what pain treatment will look like in the future. Like, will it be more geared towards mindfulness practice or manual skills? And I don't know, it'll just be interesting to see the mix of the skill set of our pain specialists in the future. But okay, so you go to OT school, you have this background already in these manual skills. What made you want to open your own practice?
Well, initially it was, I already had a practice before going to OT school and in doing the manual therapy. So I'd already built up my client base in my community. My OT school training took me out of state, but I did a weekend program twice a month and then did a lot of self-study. So I'm in Vermont, and that was at Utica College. So it was a 4.5-hour drive each way. So I was doing that 2 or 3 weekends a month. So there are times when I was on field work where I had to put my practice completely on hold because there just wasn't time to be seeing my clients. But once I had been out for a couple of years, had gotten a little bit of the skilled nursing facility experience, and felt ready to jump into my practice more full time, I sort of made the leap and transitioned into my practice more and went through the whole headache of dealing with Medicare and Blue Cross Blue Shield and Medicaid and insurance fundness and getting the systems in place so that I could bill insurance alongside of my cash-based practice that I already had in place. So I guess part of your question is relating to what made me want to do my own practice. And I think that I wanted to be able to continue to do innovative work. Like, I tend to be sort of a free thinker who wants to do what's best for my clients and that what excites me the most. And I saw that I would probably be bumping up against managers in most settings as far as having to justify what I'm doing versus just going ahead and doing it. And I'm willing to put in the work to build the right codes to make sure that it gets reimbursement stuff right, but not all managers would necessarily directly see that I was willing to put in that type of work. And I didn't want to have to slow down innovative thinking and meeting the needs of my clients by having to work under other people. Some of that's a little bit rebellious nature on my part. And yeah, I had my background in manual therapy already, and I feel like OT school tends to be, I'm really glad I'm an OT, but we tend to be real weak on the actual skills, the more tangible skills of working with people. It used to be that OTs would learn weaving and all sorts of very practical things that I'm glad I didn't have to learn weaving as part of my OT training. But at least there was a very clear practical skill we were learning, versus I feel like OT tends to teach a much higher level analysis, which is really important for being adaptable as a profession, us all being able to look at research articles and meet the needs of our clients that way. So I came into it with a set of skills already. So I feel like we all fall back on the skills we have. And my manual skills became the baseline for the work I was doing. And from there, I'm able to sort of go in the other directions that encompasses the very broad umbrella that is occupational therapy.
Yeah, that's so interesting to hear how you were able to merge those two backgrounds together. I see how they work so well hand in hand and how they would lend themselves to private practice. And I love your mention of that, like rebelliousness and innovation, because I think that is what we need in pain management right now. Like there aren't enough people focused on it. There aren't the right systems to get people the help that they need. And thinking about this article, I was just kind of blown away by this article because I think it helped me stitch together so many like thoughts that I had about pain overall, like seeing how complex it was, how much we have yet to like understand about it, and just the big need out there, like that the stat that I mentioned that like 30% of the world's population is affected by chronic pain. It's the leading cause of disability. Why aren't we more focused on it? And I guess part of the answer is because it is so complex. I don't know. What were your takeaways from this article? There was so much to unpack in there.
Well, I had a lot of takeaways, but to kind of go off what you're talking about a little bit there, the boxing in that are, I think, the healthcare, because healthcare has gotten so complex, we have people who develop these real specialists and specializations, and I feel like pain can't really be boxed in the way that we want to with the specialized medicine, and as we discussed the article a little bit more, like they were talking about that simply severing one part of the spinal cord because that's where the nociception signals are coming, or severing some part of the brain because that's where it is. Pain will find its way around that. You can't box it into a real reductionist approach. And I think that speaks to sort of why it interests me, is because I really don't believe in reductive medicine. I work in the posture and fascial work I do. I'm looking at the whole system. I'm looking at how a foot balances in with somebody's jaw. And people don't necessarily think about how does the arch of the foot relate to your jaw in more than just a like energetic way. And that's something that I sort of explore with people. I mean, not every foot is related to every jaw, but you need to be able to look outside of a reductionist approach to see if there is a connection there. The article itself was very dense, and I felt like used a lot of scientific language that I didn't feel like necessarily benefited it. It was really trying to give itself credibility to a lot of the sort of neuroscience community by using a lot of terminology that didn't make it seem as accessible. And I feel like that actually did a disservice to educating people about pain. So that's sort of starting off with my sort of critique of that. I felt like that it could have been more digestible, and because it was a position paper, it wasn't like a exact research paper having to prove its methods. I felt like it should have had the leeway to be a little bit more digestible language, because I don't. But with that said, there was so much rich information in there that I was really appreciative for what was there. But it really took me a while to get through and tease out some of the more clinically appropriate things. One of the things that I thought was really interesting was about the multiple points on pain. That if you had 2 points, if you had two injuries to your left cheek, that was actually going to hurt less than if you were, or send less signal than if you had an injury to your left cheek and your right foot. And to me, that's sort of like, if a bee stings you, if 3 bees sting you in one spot, real close to each other, that means go move that one hand away. It's not as much of a warning. But if you have a bee sting you on the face, the hand, and the foot, then you have actually more signal going to your brain overall. And I thought that was both interesting, and when I thought about it, made sense. So it was neat to hear it in those terms. Additionally, I thought there was something really interesting about 2 points in a same area. They were talking about distal and proximal in the article, and that if you had 1 point pain created, or a noxious stimulus created in like the fingertip and then in the shoulder, that they were talking about that as you brought attention to the shoulder, you'd have less in the hand. and that then when you remove the pain from the shoulder, that it would remove from the hand. It was a little unclear the exact application, but I thought there was something really interesting about that. In my clinical experience with that, I'm often thinking in terms of, is there an actual impingement in the shoulder? Is the brachial plexus pinching the nerve, causing the pain in the hand? And this made me think that there's more than just a straightforward reductionist, like, oh, the nerve was pinched, that's why it hurt down there. But we're actually re-educating that whole limb in a way that I thought that has sort of opened up my thinking, and I haven't clinically fully integrated that in, but I think that will be a takeaway for me. I was already talking about sort of I was reading the article and I started chuckling to myself at one point and said, well, pain will find a way. Sort of that regardless of where you're trying to block it, that pain's going to find a way to let you know. And that's sort of my very simplistic approach to that, but I think that it's important to realize that it's not pain finding the way, it's noxious stimulus finding the way. Because the pain doesn't exist until it's been processed in the brain and prioritized as pain. It's saying, here's a warning. The nociceptions is picking up the danger message that something, or the information that something's not right here, sending it to the brain for processing. And it wants to make sure to get it to the brain. And you throw a barricade in its way, it's going to go another channel to get that information. And then the brain decides how important that is. And I think that's one of those important things when working with neuroscience. A lot of the Adrian Lowe work is sort of getting people to realize just because you're prioritizing this in the moment and just because there's a lot of pain doesn't mean that it necessarily correlates to the degree of injury that you have or the degree of danger you're in. And those are two separate experiences. Yeah, so I thought that was interesting. The article talked about chronic pain in the beginning and then was talking about interrupting these sensors along the way. And I feel like it focused really on what I'd refer to as acute pain, or getting the message from the extremity to the brain for processing. Whereas chronic pain, my understanding is more of a condition that lives in the brain, and that centralized, that sensitization that your brain gets from saying, hey, my foot's always hurting, so any sensation to my foot is likely to be pain, and sort of magnifies any foot sensation. So it was interesting that they talked about chronic pain being such a problem and then proceeded to mostly talk about acute pain or acute sensation. And I'm curious sort of what frameworks will be coming up after this that incorporate a actual more chronic pain framework to it. And one of the things I also found very interesting is they were talking about that every brain experiences pain differently. It's not necessarily the same anatomy. So someone who's nonverbal, being in a brain scan and going, oh, they don't seem to be in any pain because they're not presenting this typical way, they might still be experiencing a lot of pain and not be able to tell you that it might just be presenting differently. So I think we tend to make, as clinicians, we have a tendency to be like, oh, the person winced, they must be in a lot of pain. Or the person didn't wince and they got a really flat affect, they must not be in any pain. And they're just matter-of-factly telling me that they've got a 7 out of 10 and they don't seem to have any pain. Do I believe them? And it becomes this, we have to believe our clients and we have to sort of dig down into what that means for their experience, which also leads me to why OTs are uniquely positioned to work with pain, which is that we talk a lot about client-centered or patient-centered, and that each person is different. Each person's nervous system is different and their circumstances around the pain is different. So I think that you have to be client-centered in that and what's important to them. So I think it really lends itself to OT in that way.
Yeah, I love hearing all these points that you pulled out, and they're actually different than what I mentioned in the review. So I hope that gives people a taste of just how much was in this article. And I really encourage people to read it in full to hear both the high level, like pain will find a way, and then these interesting findings that they highlighted related to the complexity of pain. I appreciated your first critique of it was so scientific and so dense. I was really left with feeling like I learned a lot about pain, but not in a way where I would know how to talk about it with my clients. So that was actually my first question for you is, how are you talking to clients about pain? It's honestly so complex, it feels confusing to me. How are you breaking it down for the individuals you're seeing in your practice? Do you have like a set spiel or is it individualized? I'm really curious to hear about that.
Well, when they seem receptive to it, I start usually bringing in this educational module from Adrian Lowe that I mentioned before. It's the Why You Hurt Neuroscience Education System of Pain, which does a lot of sort of flashcards, almost a PowerPoint with script to explain a lot of the really complex things in pictorial methods that I find not only help the clients, but have really helped me better understand the neuroscience of pain. You have to be careful when you're talking about pain because it is such a personalized thing. I often start with a little bit of a joke if I think the person can take it. And I say, well, the pain is all in your head. And then I sort of pause for a moment, watch them become a little uncomfortable. This is only if I have the right rapport with the client, and say, where all pain exists, all pain is all in our head. That's where the lived experience of pain is. So we need to start with that as the framework. And that sometimes turns someone off right away. And sometimes that sort of gets them on board with it. But to be like, there is no pain receptors in the body. There are nociception receptors, which could just be picking up pressure and can be processed in a lot of different ways once it meets the brain. And it's just important to realize that experience can be very different. So yeah, you can't push too much, and you have to meet someone where they're at. And it's also important to I really like to separate the two different things, that how much biomechanical problem you have in your body does not equal how much pain you're experiencing. I tell people that I'm 36 years old. If you did a full body x-ray of me, chances are you'd find osteoarthritis somewhere. And who knows, maybe it's bone on bone, probably not yet. Do I have pain in the joints that have osteoarthritis? Probably not. The person who has severe knee pain just develops severe knee pain and goes in and gets their scan and they're told they have bone-on-bone osteoarthritis and they're afraid. And they're like, well, this is bones grinding on bones. This is not good. I said, yeah, but 3 weeks ago when you didn't have pain, you probably still had bone-on-bone arthritis. So something is tipped over. You weren't afraid then. You are now. There are people who have the same degree of joint degradation without the pain, that there's something else going on. And trying to really separate out the pain experience from the biomechanical problem. Because the more I learn about neuroscience, the more I realize that those two just don't equate each other. I have a poster on my clinic wall. It's also some of the Adrian Lowe material that goes through different body parts, and so that when someone mentions the pain in their shoulder, or someone mentions whiplash in their neck, I'll be like, yeah, but I'll read off the wall from about a study, demolition derby drivers who crash on average 20 mile an hour crashes 1,500 times in their career, and most of them are not experiencing whiplash. So this is not to say that our clients who experience a traumatic whiplash don't have pain and don't have serious things that need working with, but it goes beyond just the biomechanical impact to their neck. It goes to the trauma. I mean, those demolition derby drivers are probably going, woohoo, I'm hitting someone again. Like it's really like bumper cars. Yeah. So it's how you process that. I think that trauma plays a real role in it. So realizing that if someone has pain, you're also dealing with trauma, and understanding how to help them deal with that. Additionally, and I don't know if I was going to discuss this in another section or not, but our language around pain is so lacking. Physical sensation in general, we can both look at the color blue and it's external to us and agree that it's blue. We might argue over whether or not it's sea foam or blue-green or green-blue, but there is an external reality that we can compare to each other. I can't look at you and know what it is you are physically feeling, even if I've experienced a punch to the shoulder or burn on the cheek, and I see the same happen to you. I can maybe empathize and guess that you're experiencing the same thing, but I don't really know how your system has processed that. So a lot of what I do when I'm talking about pain in general with clients is just try to tease out their language of pain. Because my language of pain doesn't really matter. It's really what they're experiencing.
Yeah, I'm just feeling so humbled thinking about the complexity of the neuroscience and then the complexity of like the individual experiences around pain and the differences in how our bodies process it, and then the language we have around it. And it almost feels like how you think about pain is existential too. It's like so big picture, like relates to your worldview, how you understand pain. Like it's just so complex. And I love hearing how you are able to individualize that and listen to the client who's just sitting in front of you. I can definitely see how that's the best approach and how that's the approach that is needed. The article ended with this kind of big picture takeaway that we're underutilizing the tremendous power of the brain to help us regulate pain. I wondered how that line in particular struck you and how and if you've seen that in your practice, especially as someone who has a tilt towards manual skills. Yeah, I was just curious about your reaction to that.
Yeah, so I think the first thing comes to mind is people's fear around pain. Well, actually, the very first thing that comes to mind in you mentioning that is that the article talks about that, but it says that in their conclusion, but then I feel like they don't actually, again, sort of to my critique of it, that they didn't actually talk about the brain's regulation. They more talked about the brain's workarounds to still experience it. And it would have been interesting to get into some of the chemistry and the regulation happening within the brain. And you can get into placebo studies around a lot of that stuff too, and I think can get very complicated. But within my own practice, taking it back to back pain and like fear of back pain that I had, that there is I was observing the Dartmouth has an interdisciplinary back pain clinic, and one of the things they do, so they've got doctors and nurse practitioners and psychologists and social workers and PTs and OTs, all working with people who have severe back pain, and they've been medically cleared as there isn't anything seriously wrong with them. None of our activities are going to actually injure them, though they might hurt. And they're having them do exercises like, okay, pick up a weight off the floor, but keep your knees bent. Lift from your back, not your knees, which is the opposite of what everyone's been told. And they're starting off with light weights, and then they're going, oh, I can lift a 1-pound weight off the floor with just my back. And I'm going to make mistakes, and I'm going to lift something with my back. I shouldn't be afraid of my back moving and being involved in it. And then the next day they're upping it to 2 pounds and then 3 pounds, or that's not the exact trajectory, but every day they are increasing the weight. I did something like that with a client who was in their 70s. She came in and she had severe back pain. She couldn't reach down and touch her toes. And prior she was able to touch her toes and touch the floor. And I would do manual therapy and desensitize her to the idea of touch. And I have a deep, firm pressure that I do. I make sure I'm checking in with people about what it is they're feeling and whether they're okay with it, and trying to develop that rapport of language with them while I'm doing that. And then in this case, I was having her then lifting up a light weight or bending down to touch her toes. And actually, the more she would do it in a session, that an indicator that exercise actually will help a pain condition is that if they go to do it, if they reach down to bend their toes, the first time it hurts, the second time if it hurts actually less and not more, then it's an indicator that exercise really is indicated for that type of injury. That if just moving that actually improves it. So I made sure that was the case first, and then I had her lifting weights up. So eventually I had her lifting the 1-pound weight with her knees straight. And eventually I had her moving from the 1-pound weight to the 2-pound, and we got up to 25 pounds. This 70-year-old woman was lifting a 25-pound dumbbell off the floor with her back. I'm doing it alongside her, and I'm getting tired, and my back's starting to get sore. I'm not saying anything because I don't want to add to this pain experience for her. So she left being able to do this tremendous amount of lifting and back to doing her heavy gardening. And that was just, a lot of that was just training her system that it was okay. That I don't think that her back did get stronger, but that was a neuromuscular education. That wasn't solely like someone went from lifting 1 pound to 25 pounds. They're 25 times stronger than they were before. That's not what was happening.
I want to ask some practical questions for OTs who have patients coming in and pain's one of the main reasons they're coming in. What are some of the assessments that you tend towards for clients in your own practice?
Well, I always do the 0 to 10 pain, the 0 to 10 pain scale, which clients hate, and I originally hated. But I do think that my 5 is going to be different than your 5. My 5 in my shoulder is going to be different than my 5 in my knee, even, because I have a different relationship to those parts of my body. But my 5 in my shoulder today, and then a 7 in my shoulder tomorrow, and a 3 in my shoulder the day after tells us something. So I do actually put a lot of stock in the fluctuations. Now I tend to give it a 2-point margin of error or more. I don't know the actual stats on that. But I do find that gives a sense of at least how I'm feeling about my pain right now, how I'm rating it, even if it feels arbitrary and subjective and not an objective measure. I think that it is an important measure. So I definitely don't want to throw that one out. I've already talked about the language of someone's sensory language and developing that language with them. Now, I might not formally write all that into notes, but really giving people the space to describe their pain, I think is a major part of my assessment. Is it radiating? When do you feel it? How are you feeling it? I don't need to get too esoteric about it, though sometimes I might, but what does it make you think about? Does it make you nauseous? There's a lot of different descriptors, and trying to get people to have a little bit of fun with their own descriptors of their pain. And I'll get to a couple more of the assessments in a moment, but thinking about people's language of pain, I had a client once who I was working deep into the back of their hip, and I was trying to get a release to their hip, and I was coming in gentle but firm the way I do, where I'm not doing anything fast. And she said, "I feel like you're sneaking in the back door in your stocking feet." And this is her experience of what I was doing with her body.
Whoa.
And I said to her, my response was, "No, I'm lounging on your couch. I'm already right where I want to be. Like, you don't need to worry about me sneaking any further. I'm actually right where I want to be."
Yeah.
So that was the language I found myself using with this person. Now, that's not exactly a formal assessment, but you got to leave room for someone to say something like that, and that's more important as to than whether or not they've checked off, whether it was achy or throbbing or dull. I mean, each of those things could interchangeably mean something different depending on the person. And no one has since told me they felt like I was sneaking through their back door in stocking feet. But to get to some of the other things, that one is I always make sure I've got a functional assessment. There are a lot of, the DASH is one that a lot of OTs are familiar with. The quick DASH is quicker and just as effective. At least my understanding is just as valid, where you're really getting into a lot of those measurable functional capacities. When Medicare required the G codes for outpatient, people were using those quite a bit. Now people aren't quite as much, but I always make sure I know what region of the body. Every region's got one of those assessments to it. There's the LEFS, the lower extremities functional scale, maybe. But so I always make sure I'm using one of those. And when I'm talking about pain and I suspect somebody's got chronic pain or hypersensitivity to pain, I use what's called the centralized sensitivity inventory, which asks all sorts of questions which might appear unrelated to each other. Some of them are, how frequently do you get headaches? Are you sensitive to smells? Do you have restless leg syndrome or jaw pain? And a lot of these things that in isolation are just their own things, but when people have say frequently to a lot of these things, and it creates this, gives you a number in the end, it gives you a sense of how sensitized this person's system might be. Sleep disturbance is another one that's in there, and I think it's like 15 or something different questions. But I find that to be very useful, and for some clients, it becomes very validating. They say, I know that my body is responding to things, and people keep telling me it's all in my head and keep telling me, like, I just need to get over it, which just because the pain is all in your head doesn't mean that you can just get over it with the snap of a finger. It means that that there's something going on in your processing, and that needs to be addressed. But to be told you have a sensitive nervous system, you've got a lot of the indicators that show that you're responding, that your body is responding with a higher pain response to things that others might not, and that's real, can be very validating. Sometimes people think there's something more seriously wrong with them, and that can be, it could be the case, and you need to leave room for that. Occasionally people will bristle at some of the education stuff, but usually the centralized sensitivity inventory makes people feel like they're being heard and can give you a real sense as to whether or not this person is predisposed towards chronic pain. Is their new injury, even if it's a fairly acute one, likely to lead to something more severe? I mean, we haven't talked about complex regional pain syndrome, which is sort of that a whole limb. Usually when OTs are working with it, it's an upper extremity that just has been injured severely enough that the whole thing just starts to create this feedback loop and swell up and have all sorts of issues that we don't need to go into now because many OTs are already familiar with. But yeah, so I would say that my long-winded answer to your go-to assessments would be the centralized sensitivity inventory, the pain scale, really making sure I'm using the language of pain that the client has, and always accompanying this with a functional assessment.
I can tell just from talking to you how holistically you're thinking about things, and kind of in one person, you're providing a lot of that multidisciplinary approach that the article talks about. I want to ask a two-part question. One, what are your treatment sessions looking like just overall for these patients, kind of the specifics of how you spend your time on treatment? And two, are there times when you loop in other professionals, and what does that look like in your network?
Yeah, so a lot of my work I start off focusing on posture. The person might have shoulder pain, and I definitely address that. But I'm looking at where's their head in relation to their shoulder, where are their feet in relation to their shoulder, how is their sternum and their ribs, how is their breathing, because that's the foundation that the scapula is resting on. So I go through my manual therapy. I have a systematic approach that when I'm just doing this, which is when I'm doing insurance-based clients and getting into more complex circumstances, I'm often not doing this. But there is a structural integration. It used to be called, and still is called, Rolfing, but I didn't go to the Rolf Institute, so I can't say I have trained in that name brand. But there is a protocol of going through all the fascial layers, all the different areas of the body to sort of tonify and open up the areas that are restricted and opportunity to educate the body in a whole system, myofascial tonic sort of way. And I could speak at length to that, but I won't entirely right now. So I'm not always working the areas that are directly affecting the pain. I think about distal and proximal. That's one of the reasons I latched onto that from the article, that if someone's got a hand pain, I might be working at the shoulder in addition to the hand. Even if the person's got carpal tunnel and we know they have a restriction in their carpal tunnel, chances are there's something about their posture and how they're holding themselves at the computer. Chances are there's still some restrictions in the brachial plexus, even though most of the impingement is in the carpal tunnel and at the elbow. And to get someone connecting in that whole limb and even taking it so far as, well, then how is that resting on the ribs? How's your scapula resting on your ribs? How is your rib basket or rib cage articulating with your hips in your low back? How is that angle relationship? And how does that actually relate to how your feet are meeting the floor? So the foot and how that meets the foot and ankle to the knee to the hip is all stacking up and affecting this carpal tunnel. So I do take that holistic approach to addressing someone's pain. And I think that the hands-on approach that I have is educating the nervous system. Something that a client who I worked with for years had mentioned once was, I used to be really ticklish, and it just occurred to me, someone tried to tickle me the other day, and I'm not ticklish anymore. I think it's because I've been getting work from you for so long. And to me, being ticklish is a sense of discomfort or uncertainty in a physical sensation. I don't know what that is, kind of laughing. And we can get into a lot of different ticklish stuff. But I'm working in people's armpits. I'm working up in some of the deep groin muscles. I'm working in the back of the knees. I'm actually at times working inside people's mouths and nasal passageways. I'm building up trust and rapport with them as we go. And by working all these areas, I'm helping to remap the body's relationship. It's sort of, I think of it a lot of times as taking inventory, helping the brain take inventory of, oh, I forgot that tissue was there. I could actually be paying more attention to that, or that could open up more, is something that I feel like the brain is doing in response to the work. I talk about fascia a lot, and for those who don't know what fascia is, it's covered briefly in every Anatomy and Physiology 1 course as sort of embryologically speaking, that's that tissue that's that connective tissue dump category, and fascia is that thing that surrounds some of our organs and such. Well, the reality is it surrounds and permeates almost every organ in the body. The outer layer of bones that we think that is actually where it hurts the most when you break a bone is fascia, periosteum. The outer layers of the brain, we know the dura mater and the pia mater, those are fascial layers. You have intermuscular fascia that goes between groupings of muscle fibers. You have extramuscular fascia that wraps individual muscles and muscle groups. And then at the end, that turns into tendons. And I would say turns into, that the tendons and ligaments are exactly the same material of fascia as the other things that we're calling fascia. They're just different density and arrangements of collagen fibers. So the muscular fascia is continuous in this like multidimensional spider web to the outer layer of it, to the tendons, to the bone. So the outer wrapping of the bone is the same material as the inner of the muscle, and it's just been stretched and pulled in as we've grown and differentiated. That I think of it as our muscles are actually floating in a fascial web. There are these muscle fibers floating in this fascial web that gives them structure. So when we think about muscles' main job is to contract. And fascia cells are 10 times more innervated with sensory nerves. So our map of in our brain of where our body is and what we're experiencing in our body, when we're feeling our muscle, we're much more likely to actually be experiencing the fascia that's the coating around it and is the network that's holding it together than the muscle fiber itself. So, which at first that seems pretty far out there, like, well, no, my muscle hurts. But when you think about it, muscle fibers are meant to contract, as we said. They're specialized cells for contracting and motor nerves that we've differentiated cells so that they can have different purposes. The fascia is actually much more in the position to be a sensory organ. So our muscles are wrapped in fascia, which gives them structure and helps feed the sensory experience back to the brain. Now we know the Golgi tendons, which tell us how much tension is on a muscle, are actually in the tendons. That it's the nerves in the tendons that are sending back how much tension is on it, which is what gives us our sense of proprioception, where our joints are in space and the tension on those. So our sensory experience is in our fascia, and I'm working with the myofascia of the body so that I'm not just getting in there and changing the position of the fascia, even though that's what I feel like. I'm actually working with the nervous system and its relationship the whole time. So I'm tapping into sort of the brain's power to heal and the brain's complexity, and I'm helping people with a rich sensory experience. So I think of this, and I've been talking about the muscle, but the same is true as we said, like all of our stomach is wrapped in fascia. All of our different organs are wrapped in fascia. I just don't tend to specialize in the more visceral work. So that is a holistic approach to pain that I come from. And I hadn't thought of it specifically as treatment of pain because I'm thinking about posture and ease of motion, which is the functional aspect, and the postural aspect had been the goal. But now that I'm better understanding pain, I'm realizing that I'm interfacing with the nervous system differently. So that was a lot, I know. And that sort of helps answer the first part of your question, which is sort of what it is I'm doing.
Yeah.
And I definitely don't pretend it's a one-stop shop. People come to me usually either because they have a distrust for the more mainstream medical system. They've heard great things about me from someone else who might have a distrust of the mainstream medical system, or they haven't gotten their needs met in a more conventional rehab setting. So I tend to be a little bit on that fringe. I was more on the fringe before I became an OT. I became an OT so that I could help translate into that and help people have their insurance cover it. So I'm very familiar with a lot of alternative approaches. I don't pretend to be practitioners of them, but I can talk with people about the shamanic experience they had. I'm not a shamanic practitioner. I don't do those trance things. I haven't experienced them myself, but I can speak in that language to people. I'm not afraid of speaking to shamans about that work. I can talk to, I frequently talk with acupuncturists, and some of my massage school training before I did my structural integration training included a lot of shiatsu and an understanding of Chinese medicine. I'm married to an herbalist and the child of an herbalist, so herbal medicine and the idea of finding your own medicine from your landscape is not unfamiliar to me. Ayurvedic principles and chakras and auras and all of that stuff are things that I might fluctuate in my own belief as to whether they are real, but the reality is they're a language that clients are coming from, and that they're the framework that they're working from. And the client's framework matters way more than mine. I might sort of say, hey, I hear all that. Let me try to translate that into what I can offer you. So in that way, it's a very multidisciplinary approach in the sense that I can speak to a lot of these different healthcare practices. I've done panels with different healthcare practitioners where we've discussed a fairly esoteric acupuncturist and an herbalist and a naturopath all in the same room discussing what is fibromyalgia, what is Lyme disease. I've hosted some of those discussions, and I also have a podcast where I interview different healthcare practitioners, primarily local, but if there's the right person further out, I do that as well. So I'm connected in with my community, so I can develop my interdisciplinary team even if I am not under the same roof with them.
That has my mind spinning about so many things. First of all, like hearing about your treatment approach is helping me to meld in my mind how manual therapy is so tied to education, and almost like I hear a kind of mindfulness that is going on with your patients, even though that may not be the explicit way that you're thinking about it, but I'm like, that's helping them become more mindful of their pain and educating them. And it's all centered in this manual approach, and kind of breaks down the lines between those approaches for me. Like it's all melded together, which is really interesting, which I guess goes back to like pain cannot be kept in a box. And then same thinking about the multidisciplinary team. When you're talking about pain, you're going to be interfacing with the patient's worldview in a really interesting way. And as OTs, we need to enter into whatever their worldview is and hopefully use some of that language and try to connect on that in a way that's helpful. And I love hearing how you interface with all these different disciplines in your community. Just like I felt after reading the article, my mind was spinning after that. And I've had so many thoughts during this interview that I'm excited to just keep thinking about. But to close us today, I'm really curious what advice you would give to an OT who's looking at opening a practice where they see clients with pain. I'm just hearing today how much we need more OTs doing this work. What advice do you have for those OTs?
If you're starting your own practice, don't try to do it all your own from scratch. Really seek out not the really expensive ones. I don't tend to suggest that, but having business consultants, having accountability partners, those kind of things really do help. And don't throw a lot of money into it to begin with. Start slow and see if things work. Everything's going to, the practice you think you're going to have now is going to be entirely different. So don't invest huge amounts of money and time into one idea. Just get moving and just try something out and do it and see if it works. And if it's not working, assess whether it's because you didn't do it the way you wanted to or because you're not heading in the direction you want. So keep the day job for a while and play with it on the side is what I sort of was doing right out of school until you know you've really got a model that works. And then you can start investing into it. So those are my business pieces of advice there.
Oh, that's so helpful. And I know that's hard-won advice. And I have a totally different kind of business than yours. And that really resonates with my experience as well. And just that finding where your skills meet the world's needs is, I think, the central thing as OTs that we're all doing. Irvin, we've talked about so many things today. This has been so much fun. I could just keep talking and asking more questions, but what's the final thought you want to leave us with today?
When it comes to pain, the brain and pain are complex, and I want people to leave understanding that there is not as strong a link as we might think between the amount of pain we experience and the biomechanical problem.
Yeah, that so perfectly summarizes this article that we looked at and just a space for OTs in there to help be a part of this. This is such a huge need around our world to have more people working with chronic pain and to have those innovative and, like you said, like almost rebellious approaches are so needed right now in our system. So thank you so much for sharing with us today about your thinking and your approach. And thank you for the work that you're doing in Vermont and just all the clients that you're seeing there. It's been a real pleasure talking with you today.
Well, thank you for the opportunity. I really love what you're doing with the OT potential and really digging into different articles and aspects of OT and helping push the profession forward. Thank you.
Wow, you all, this was just another mind-stretching interview for me. The neuroscience of pain is so fascinating, and my mind is really just working on this need for more practices specializing in pain. It was great to hear how Irvin combines his bottom-up manual therapy with a top-down occupational therapy approach. I'm excited to keep exploring pain in the future, and a great way to help us find your practice to highlight is to join the OT Near Me directory. Not only will this help fellow OTs find you, it will also help the clients in your community to find you. And if you are interested in earning a CEU certificate for your time today, what you are going to do next is head to otpotential.com and either sign in or sign up for the OT Potential Club. Once you are in there, you can take a 5-question test, and when you pass, we will generate a certificate for your time today. And as always, I wanted to thank you so much for joining us. I hope this podcast helps keep you informed and inspired as an OT professional. Take care, and we'll talk next time.
Well, it was fun being interviewed on that podcast. I hope you enjoyed it as well. Come back next week, and we'll have a regular episode of me interviewing someone else and playing host again. Until then, take care.